Good day, class. I'm Dr. Cecil Melis B. Derecho. This chapter will deal mainly on the treatment of inflammation, pain, fever, and gout. Most of the content of this lecture is taken from the textbook Pharmacological Basis of Therapeutics by Goodman and Gilman. Pictures are sourced from the internet and are used for better visualization of the meaning of the texts. Please read this chapter from our textbook so you will better understand the topic. I did not receive any honorarium from any pharmaceutical company for this lecture. All the statements and opinions expressed in this presentation are those of the speaker and are based on reference from the published sources in the medical literature, including the textbook of Goodman and Gilman's Pharmacological Basis of Therapeutics. Here are my objectives. This chapter discusses the non-steroidal anti-inflammatory drugs or NSAIDs, which are used to treat inflammation, pain, and fever. This chapter also discusses the drugs used for hyperuricemia and gout. The inflammatory response is characterized by transient local vasodilation, increased capillary permeability, infiltration of leukocytes and phagocytic cells, and resolution with or without tissue degeneration and fibrosis. There are many molecules that are involved in the promotion and resolution of the inflammatory process, such as histamine, bradykinin, serotonin, prostanoids, LTs, PAF, and an array of cytokines, which are all important mediators of inflammation. Prostanoid biosynthesis is significantly increased in inflamed tissues. Prostaglandin E and prostacyclin, or PGI, are the primary prostanoids that mediate inflammation. They increase local blood flow, vascular permeability, and leukocyte infiltration through activation of their respective receptors such as the AP2 and IP. So for pain, peripheral sensitization happens after an injury in the peripheral nerve as well as in tissue injury and inflammation. So after an injury, endogenous chemicals or the mediators of inflammation are released from the site of tissue injury or inflammation, and these can activate and sensitize the peripheral sensory neurons called the nociceptors, and this results in peripheral sensitization, thereby increasing the pain perception. These inflammatory mediators like the PGE2 and PGI2 or prostacyclin reduce the threshold to stimulation of nociceptors causing peripheral sensitization. Reversal of this peripheral sensitization is the basis for the analgesic activity of NSAIDs. A similar sensitization phenomenon can take place in the central nervous system, and this is called central sensitization. This can be initially induced by peripheral sensitization. Centrally active PGE2 and perhaps also PGD2, PGI2, and PGF2A contribute to central sensitization. An increase in the excitability of the spinal dorsal horn neurons that causes hyperalgesia and allodynia, in part by this inhibition of glycinergic pathways. The peripheral sensitization and central sensitization together produce neuropathic pain and inflammatory pain reflected as allodynia and hyperalgesia. Allodynia is the experience of pain from stimuli that is not normally painful. For example, when you have a migraine, you will often describe this experience by saying, "My hair hurts," especially when you brush it. However, there is no satisfactory therapy for the management of allodynia and hyperalgesia. Central sensitization reflects the plasticity of the nociceptive system that is invoked by injury and is usually reversible within hours to days. The body temperature is maintained by the hypothalamus regulation of a certain set point. This set point is elevated in fever and usually happens after an infection or from tissue damage, inflammation, graft rejection, or malignancy. These conditions all enhance formation of cytokines such as interleukin-1b, IL-6, TNF-alpha, and interferons, which act as endogenous pyrogens, which stimulates COX-2 enzymes, increasing PGE2 synthesis in the hypothalamus. This then increases heat production and shuts down the heat-losing mechanism, and finally, raising the body temperature causing fever. The NSAIDs are classified as isoform non-selective NSAIDs, which inhibit both COX-1 and COX-2 or cyclooxygenase 1 and cyclooxygenase 2, and COX-2 selective NSAIDs. Most NSAIDs are competitive, non-competitive, or mixed reversible inhibitors of the COX enzymes or cyclooxygenase enzyme. Aspirin or ASA is a non-competitive irreversible inhibitor because it acetylates the isozymes in the arachidonic acid binding channel. Acetaminophen, which is antipyretic and analgesic but largely devoid of anti-inflammatory activity, acts as a non-competitive reversible inhibitor by reducing the peroxide site of the enzymes. Both isoform non-selective NSAIDs and the cyclooxygenase 2 selective NSAIDs generally are hydrophobic drugs, which allows them to access the hydrophobic arachidonic acid binding channel and results in shared pharmacokinetic characteristics. Aspirin and acetaminophen are exceptions to this rule. There are three mechanisms of action of NSAIDs. First is the cyclooxygenase inhibition. Second is irreversible cyclooxygenase inhibition by aspirin, and selective inhibition of cyclooxygenase 2. Let us discuss first the cyclooxygenase. So what is a cyclooxygenase? This is a rate-limiting enzyme involved in the conversion of arachidonic acid to prostaglandin H2, which is the precursor of several molecules including prostaglandins, prostacyclin, and the thromboxane. NSAIDs, therefore, when given to a patient, has its therapeutic effects mainly derived from their ability to inhibit the prostaglandin production. Their ability to inhibit the prostaglandin production will now reverse the actions of your cyclooxygenase. And they act on the first enzyme in the prostaglandin synthetic pathway, which is the cyclooxygenase. The enzyme cyclooxygenase 1 or COX-1 is expressed constitutively in most cells and is the dominant source of prostanoids. These enzymes function for housekeeping like gastric protection or gastric cytoprotection, vascular homeostasis, platelet aggregation, and kidney function. This is stimulated by hormones or growth factors. On the other hand, cyclooxygenase 2 or COX-2 is usually undetectable in most tissues. Its expression is increased during states of inflammation. That is why they are inducible. This enzyme is induced by cytokines, shear stress, and tumor promoters. And this is the more important source of prostanoid formation in inflammation and perhaps in cancer. But studies now say that COX-2 is also constitutively expressed in the brain, kidney, bone, and probably in the female reproductive system. However, both COX-1 and 2 contribute to the generation of the autoregulatory and homeostatic prostanoids with important functions in normal physiology. So what happens now if you give drugs like NSAIDs? Let us take as examples the GIT and platelets. We know that COX-1 is a dominant cytoprotective isoform in gastric epithelial cells and also forms thromboxane A2 in platelets, which amplifies platelet activation and constricts blood vessels at the site of injury. Therefore, drugs that inhibit COX-1 and COX-2, we'll start with COX-1 first, will now cause the opposite effect. Instead of gastric protection or cytoprotection and platelet activation, you will now have the gastric adverse events and bleeding. and this will now complicate your therapy. On the other hand, COX-2-derived products also play important roles in blood pressure regulation and act as endogenous inhibitors of homeostasis. The inhibition of COX-2 by NSAIDs can cause or exacerbate hypertension and increases the likelihood of thrombotic events. Most NSAIDs inhibit the catalytic subunits of COX-1 and COX-2. So this one is the catalytic subunit. However, COX-2 inhibition by naproxen and fluorbiprofen occurs primarily in the allosteric subunit. Aspirin covalently acetylates the catalytic subunits of the COX-1 and COX-2 dimers and irreversibly inhibiting your COX activity. This is an important difference from all the other NSAIDs because the duration of aspirin's effect is related to the turnover rate of the COX in different target tissues. The importance of enzyme turnover in recovery from aspirin action is mostly noted in platelets. Platelets being anucleate, which means they lack a cell nucleus, have limited capacity for protein synthesis, and because of this reason, platelets cannot generate new cyclooxygenase. So, when aspirin is given, its effects on platelet last for the duration of the life of the platelet. Platelet formation recovers fully once therapy has been stopped, which is around 8 to 12 days, and it takes an average of 10 days before aspirin's effect on platelets wear off. After giving a single dose of aspirin, platelet activity or platelet COX activity recovers by 10% per day as a function of platelet turnover. Inhibition of platelet COX-1 dependent thromboxane A2 formation, therefore, is cumulative with repeated doses of aspirin, at least as low as 30 milligrams per day. And even a partially recovered platelet pool just a few days after the last aspirin dose may already be good enough for the recovery of sufficient hemostatic integrity, especially important during some types of elective surgery. In contrast to aspirin, salicylic acid has no acetylating capacity. It is a relatively weak reversible inhibitor of COX. Salicylic acid derivatives rather than acid are available for clinical use. The chronic use of the NSAIDs is limited by their poor GI tolerability. Selective inhibitors of COX-2 have similar efficacy to the traditional NSAIDs but with better GI tolerability. There are 6 COX-2 inhibitors called the COXIBs that were initially approved for clinical use, and these are the celecoxib, rofecoxib, valdecoxib, and its prodrug parecoxib, etoricoxib, and lumiracoxib. Most of these have been either restricted in their use or withdrawn from the market because of their adverse cardiovascular risk profile. Today, celecoxib is the only COX-2 inhibitor that is licensed for use in the US. Selective inhibitors of COX-2 also include some older NSAID compounds like the diclofenac, etodolac, meloxicam, and nimesulide, which is this nimesulide is not available in the US. These drugs exhibit selectivity for COX-2 that is close to that of celecoxib. So let us discuss the pharmacokinetics of NSAIDs, or the ADME: absorption, distribution, metabolism, and excretion. The NSAIDs are rapidly absorbed following oral ingestion, and the peak plasma concentration are reached within 2 to 3 hours. NSAIDs have poor aqueous solubility. Food intake may delay absorption and systemic availability, that is phenoprofen and sulindac. Antacids commonly prescribed to patients on NSAID therapy variably delay absorption. Some compounds like diclofenac and nabumetone undergo first pass or pre-systemic elimination. Aspirin begins to acetylate platelets within minutes. For distribution, most NSAIDs are extensively bound to plasma proteins around 95 to 99% and usually albumin. These highly protein-bound NSAIDs have the potential to displace other drugs if they compete for the same binding sites. Most NSAIDs are distributed widely throughout the body, and they readily penetrate the arthritic joints, and most NSAIDs achieve sufficient concentrations in the CNS to have a central analgesic effect. Celecoxib is particularly lipophilic and moves readily into the CNS. Multiple NSAIDs are sold as topical agents applied on inflamed or injured joints, and detectable concentrations in the synovial fluid of some agents like diclofenac following topical use are primarily attained through dermal absorption and systemic circulation. Methods designed to enhance transdermal delivery, such as your iontophoresis or chemical penetration enhancers, are now being studied. Topical application is also being explored as a delivery route for drug combinations containing narcotics and NSAIDs. For the metabolism and excretion, hepatic biotransformation and renal excretion are the principal routes of metabolism and elimination of the majority of NSAIDs. Plasma half-life varies considerably among NSAIDs. Ibuprofen, diclofenac, and acetaminophen have a half-life of 1 to 4 hours, while piroxicam has a half-life of about 50 hours at steady state. Naproxen has a comparatively long but highly variable half-life ranging from 9 to 25 hours. Genetic variation in the major metabolizing enzymes and variation in the composition of intestinal microbiota may contribute to variability in metabolism and elimination. Elimination pathways frequently involve oxidation or hydroxylation. Several NSAIDs or their metabolites are glucurinated or otherwise conjugated. In some cases, such as the propionic acid derivatives naproxen and ketoprofen, the glucuronide metabolites can hydrolyze back to form the active parent drug when, when the metabolite is not removed efficiently due to renal insufficiency or competition for renal excretion with other drugs. And these may prolong elimination of the NSAID significantly. In general, NSAIDs are not recommended in the setting of advanced hepatic or renal disease due to their adverse pharmacodynamic effects. NSAIDs usually are not removed by hemodialysis, except salicylic acid. NSAIDs provide mostly symptomatic relief from pain and inflammation associated with musculoskeletal disorders, such as rheumatoid arthritis and osteoarthritis. Some NSAIDs are approved for the treatment of ankylosing spondylitis and gout. NSAIDs are effective against inflammatory pain of low to moderate intensity. Even if maximal efficacy is less than the opioids, the NSAIDs do not have the unwanted adverse effects in the CNS by opioids, such as respiratory depression and the potential for development of physical dependence. NSAIDs can be given with opioid to reduce the opioid dose needed for sufficient pain control and reduce the likelihood of adverse opioid effects. NSAIDs are given for fever if fever in itself is deleterious. The prostaglandins are implicated in the maintenance of patency of the ductus arteriosus and indomethacin, ibuprofen, and other NSAIDs that have been used in neonates to close the inappropriately patent ductus. The permanent suppression of platelet thromboxane 8-2 formation that is thought to underlie the cardioprotective effect of aspirin. Aspirin reduces the risk of serious vascular events in high-risk patients, those with previous myocardial infarction, by 20 to 25%. The reduction of subsequent thrombotic stroke is somewhat less, roughly around 10 to 15%. This is according to the Antithrombotic Trialists collaboration in 2009. There are other clinical uses of NSAIDs such as systemic mastocytosis, niacin tolerability, Bartter syndrome, and cancer chemoprevention. This table shows us the different organ system affected by intake of NSAIDs. As you can see, you have your gastrointestinal, platelets, renal, cardiovascular, neurologic, reproductive, hypersensitivity, hematologic, hepatic, dermatologic, respiratory, and of course, other adverse effects. So please be familiar with all these effects. The most common of these symptoms are associated with the GI symptoms, accounting to 40% of patients with GI symptoms. They usually have dyspepsia, abdominal pain, anorexia, nausea, and diarrhea. However, these symptoms are not predictive of gastric intestinal lesions, which can be seen endoscopically in 30 to 50% of NSAID users, and they are often asymptomatic and tend to heal spontaneously. Serious complications such as bleeding, perforation, or obstruction occur at an annual rate of 1 to 2% in regular NSAID users. The risk is particularly high in those with H. pylori infection, heavy alcohol consumption, or other risk factors for mucosal injury, including the concurrent use of glucocorticoids. All selective COX-2 inhibitors are less prone to induce gastric ulcers than equally efficacious doses of non-selective NSAIDs. It is written that there is a human mutation of the receptor of the prostanoids which disrupts its signaling and is associated with increased cardiovascular risk. Results of clinical trials with celecoxib, valdecoxib, and rofecoxib showed an increase in the incidence of myocardial infarction, stroke, and vascular death. And this is around 1.4 times increased. So the risk extends to diclofenac, which is almost as COX-2 selective as celecoxib, and also to some other older NSAIDs. An exception in some individuals may be the naproxen. All NSAIDs share a black box warning contraindicating their use for the treatment of perioperative pain in the setting of your CABG surgery or coronary artery bypass graft surgery. The cardiovascular risk appears to be conditioned by factors influencing drug exposure, such as dose, half-life, degree of COX-2 selectivity, potency, and treatment duration. So, the lowest possible dose should be prescribed for the shortest possible period. All NSAIDs have been associated with renal and renovascular adverse events. Up to 5% of regular NSAID users can be expected to develop hypertension. Clinical studies say that complications of hypertension is more common in patients treated with COX-2 selective than with non-selective NSAIDs. Heart failure risk is roughly doubled, and these NSAIDs have little effect on renal function or blood pressure in healthy human subjects. In situations that challenge the regulatory systems, such as dehydration, hypovolemia, CHF, hepatic cirrhosis, chronic kidney disease, and other states of activation of the sympathoadrenal or renin-angiotensin systems, the regulation of renal function by prostaglandin formation becomes crucial. NSAIDs impair the prostaglandin-induced inhibition of both the reabsorption of chloride and the action of antidiuretic hormone, which may result in the retention of salt and water. Inhibition of COX-2-derived prostaglandins that contribute to the regulation of renal medullary blood flow may lead to a rise in blood pressure, increasing the risk of cardiovascular thrombotic events and heart failure. NSAIDs promote reabsorption of potassium as a result of decreased availability of sodium at the distal tubular sites and suppression of the prostaglandin-induced secretion of renin. Myometrial COX-2 expression and levels of prostaglandin E2 and PGF2A are increased in the myometrium during labor, so NSAIDs are said to prolong gestation in humans. Some NSAIDs, like indomethacin, have been used off-label to stop preterm labor. However, this use is associated with closure of your ductus arteriosus and impaired fetal circulation in utero, especially in fetuses more than 32 weeks of gestation. COX-2 selective inhibitors have been used also as off-label tocolytic agents. This use has been associated with stenosis of the ductus arteriosus and oligohydramnios. Low-dose aspirin, as low as 81 milligrams per day, reduces the risk of preeclampsia by 24% when used as off-label for preventive medication after 12 weeks of gestation in women who are at high risk. Hypersensitivity symptoms to aspirin and NSAIDs range from vasomotor rhinitis to shock. Aspirin intolerance, including aspirin-associated asthma, is a contraindication to therapy with any other NSAID because of cross-sensitivity. Although less common in children, this cross-sensitivity may occur in 10 to 25% of patients with asthma, nasal polyps, or chronic urticaria, and in 1% of apparently healthy individuals. Treatment of aspirin hypersensitivity is similar to that of other severe hypersensitivity reactions with support of vital organ function and administration of epinephrine. Aspirin resistance is rare, and all forms of treatment failure with aspirin have been collectively called aspirin resistance, but pharmacological resistance to aspirin is rare. So pseudo-resistance reflects delayed and reduced drug absorption and complicates enteric-coated but not immediate release aspirin administration. Hepatotoxicity. For this, liver injury occurs in 17% of adults with unintentional acetaminophen overdose. And liver toxicity from therapeutic doses of acetaminophen is, however, rare, but diclofenac given as treatment dose may have hepatotoxicity as complication. All NSAIDs class has a rate of less than 1 liver injury per 100,000 patients on average, but chronic consumption of your diclofenac is associated with an increased risk of 6 to 11 liver injuries per 100,000 users. NSAIDs are not recommended in advanced hepatic or renal disease. Ray's syndrome. Due to the possible association with Ray's syndrome, aspirin and other salicylates are contraindicated in children and young adults less than 20 years of age, especially those with viral illnesses associated with fever. Ray's syndrome is a severe and often fatal disease and is characterized by an acute onset of encephalopathy, liver dysfunction, and fatty infiltration of the liver and other viscera. Acetaminophen and ibuprofen have not been implicated in Ray's syndrome, and are the agents of choice for antipyresis in children and young adults. Epidemiological studies suggest that combination therapy of aspirin and NSAIDs increase significantly the likelihood of GI adverse events compared to either class of NSAID alone. In addition, because platelet COX-1 has been occupied already by your NSAID, this will not allow aspirin to access its acetylation target serine 529 and therefore prevent irreversible inhibition of platelet function. These usually occur with ibuprofen and naproxen and may also affect other isoform non-selective NSAIDs and not with COX-2, but confers a direct cardiovascular hazard. The ACE inhibitors act at least partly by preventing the breakdown of kinins that stimulate prostaglandin production. ACE inhibitors also can produce marked hyperkalemia, leading to cardiac arrhythmia, especially in the elderly and in patients with hypertension, diabetes mellitus, or ischemic heart disease. Corticosteroids and selective serotonin reuptake inhibitors may increase the frequency or severity of GI complications when combined with NSAIDs. NSAIDs may augment the risk of bleeding in patients receiving warfarin. Patients taking lithium should be monitored because NSAIDs, including aspirin, reduce the renal excretion of this drug and can lead to toxicity. Here are the uses of NSAIDs in children. It can be used for treatment of fever, pain, postoperative pain, inflammatory disorders, Kawasaki disease, relief of ocular itching due to seasonal allergic rhinitis, and postoperative inflammation after cataract extraction. Remember that aspirin is avoided in pediatric populations due to its potential association with Reye syndrome, but it is given in high doses, around 30 to 100 milligrams per kilograms per day, to treat children during the acute phase of Kawasaki disease, and it is followed by low-dose antiplatelet therapy in the subacute phase. The pharmacokinetics of acetaminophen, which is the most commonly used NSAID in children, differ between neonatal period and older children or adults. The systemic bioavailability of rectal acetaminophen formulations in neonates and preterm babies is higher than in older patients. Acetaminophen clearance is reduced in preterm neonates, probably due to their immature glucuronide conjugation system, or wherein desulfation is the principal route of biotransformation at this age. So, acetaminophen dosing intervals need to be extended around 8 to 12 hours, or daily doses reduced to avoid accumulation and liver toxicity. Aspirin elimination also is delayed in neonates and young infants compared to adults, raising the risk of accumulation. Disease also may affect NSAID disposition in children. For example, 80% in children with cystic fibrosis will have ibuprofen plasma concentrations that are reduced and clearance increased. Aspirin's kinetics are markedly altered during the febrile phase of rheumatic fever or Kawasaki vasculitis. The reduction in serum albumin associated with these conditions causes an elevation of the free salicylate concentration, which may saturate renal excretion and result in salicylate accumulation to toxic levels. The clearance of many NSAIDs is reduced in the elderly due to changes in hepatic metabolism and creatine clearance. NSAIDs with a long half-life and primarily oxidative metabolism like piroxicam, tenoxicam, and celecoxib have a diminished capacity of plasma albumin to bind drugs in older patients. So, will result in higher concentrations of unbound NSAIDs. And this then gives the elderly a higher susceptibility to GI complications because of an elevation in total or free NSAID concentrations. So with elderly patients, we should initially give NSAIDs at a low dose and increase only the dose if the therapeutic efficacy is not sufficient. This table shows us aspirin and diflucinal pharmacokinetics, its dosing and comparison to aspirin. Please familiarize also yourself with this table. We will discuss briefly each column in the next slides. We'll start with aspirin and other salicylates. The salicylates include the following: aspirin, salicylic acid, methyl salicylate, diflucinal, salsalate, oxalazine, sulfasalazine, balsalicide, choline magnesium trisalicylate, magnesium salicylate, mesalamine, and salicylamide. All of these are your salicylates. Salicylic acid is so irritating that it can only be used externally. Therefore, the many derivatives of this acid have been synthesized for systemic use. Aspirin is an acetate ester of salicylic acid, and aspirin is widely used as analgesic, antipyretic, and anti-inflammatory agent. The effects of aspirin are largely caused by its capacity to acetylate proteins, as was described earlier in the discussion of the irreversible cyclooxygenase inhibition by aspirin. Orally ingested salicylates are absorbed rapidly, partly from the stomach, but mostly from the upper small intestine. The peak plasma level is reached in about an hour. The rate of absorption depends on the disintegration and dissolution rates of the tablets administered, the pH at the mucosal surface, and gastric emptying time. The presence of food delays absorption of salicylates. Rectal absorption of salicylate usually is slower than oral absorption and is incomplete and inconsistent. Salicylic acid is absorbed rapidly from the intact skin, especially when applied in oily liniments or ointments, and systemic poisoning has occurred from its application to large areas of skin, like in the case of methyl salicylate. This methyl salicylate is likewise absorbed fast when applied cutaneously, but its GI absorption may be delayed many hours, making gastric lavage effective for removal, even in poisonings that present late after oral ingestion. Enteric coating delays and reduces the bioavailability of aspirin by roughly half and renders absorption more variable in the presence of food. These drugs are distributed throughout most body tissues and transcellular fluids, primarily by pH-dependent processes. Salicylates are transported actively out the CSF across the choroid plexus. These drugs readily cross the placental barrier. Ingested aspirin mainly is absorbed as such, but some enters the systemic circulation as salicylic acid after hydrolysis by esterases in the GI mucosa and liver. Roughly 80 to 90% of the salicylate in plasma is bound to proteins, especially albumin. The proportion of the total that is bound declines as plasma concentrations increase. Hypoalbuminemia, as may occur in rheumatoid arthritis, is associated with a proportionately higher level of free salicylate in the plasma. Salicylate competes with a variety of compounds for plasma protein binding sites. These include thyroxine, triiodothyronine, penicillin, phenytoin, sulfine, pyrazone, bilirubin, uric acid, and other NSAIDs such as naproxen. Aspirin is bound to a more limited extent. However, it acetylates human plasma albumin in vivo by reaction with the E-amino group of lysine and may change the binding of other drugs to albumin. Aspirin is rapidly deacetylated to form salicylic acid by spontaneous hydrolysis or esterases located in the intestinal wall, red blood cells, and the liver. The three chief metabolic products are salicylic acid, ether or phenolic glucuronide, and the ester or acyl glucuronide. Salicylates and their metabolites are excreted in the urine, and the excretion of free salicylates is variable and depends on the dose and the urinary pH. The plasma half-life for aspirin is about 20 minutes and for salicylate is 2 to 3 hours at antiplatelet doses, rising to 12 hours at usual anti-inflammatory dose, and the half-life of salicylate may rise to 15 to 30 hours at higher therapeutic doses or when there is intoxication. This dose-dependent elimination is the result of limited capacity of the liver to form salicylic acid and the phenolic glucuronide, resulting in a larger proportion of unchanged drug being excreted in the urine at higher doses. The analgesic antipyretic dose of aspirin for adults is 325 to 1,000 milligrams orally every 4 to 6 hours. It is only rarely used for inflammatory diseases such as arthritis, spondyloarthropathies, and systemic lupus erythematosus. NSAIDs with a better GI safety profile are preferred. The anti-inflammatory doses of aspirin, as might be given in rheumatic fever, range from 4 to 8 grams per day in divided doses. The maximum recommended daily dose of aspirin for adults and children 12 years or older is 4 grams. The rectal administration of aspirin suppositories may be preferred in infants or when the oral route is unavailable. Diflunisal is a difluorophenyl derivative of salicylic acid that is not converted to salicylic acid in vivo. It is a competitive inhibitor of COX and a potent anti-inflammatory drug, but is largely devoid of antipyretic effects, perhaps because of poor penetration into the CNS. The drug has been used primarily as an analgesic in the treatment of osteoarthritis and musculoskeletal strains or sprains. For rheumatoid arthritis or osteoarthritis, 250 to 1,000 milligrams per day is administered in 2 divided doses for diflunisal, and diflunisal may produce fewer auditory side effects and appears to cause fewer and less intense GI and antiplatelet effects than aspirin. Mesalamine or 5-aminosalicylic acid or 5-ASA is a salicylate that is used for its local effects in the treatment of IBD or inflammatory bowel disease. Oral formulations that deliver drug to the lower intestines are efficacious in the treatment of inflammatory bowel disease, in particular ulcerative colitis or UC. It is also available as a rectal enema and as a rectal suppository. Mesalamine derivatives in clinical use include balasalazide, sulfasalazine, and osalazine. The keratolytic action of free salicylic acid is employed for the local treatment of warts, corns, fungal infections, and certain types of eczematous dermatitis. Methyl salicylate or oil of wintergreen is common ingredient of ointments and deep heating liniments used in the management of musculoskeletal pain. The cutaneous application of this can result in an active and even toxic systemic salicylate concentrations, especially in children, and can increase prothrombin time in patients receiving warfarin. Salicylates increase oxygen consumption and carbon dioxide production, especially in skeletal muscle, at anti-inflammatory doses, a result of uncoupling oxidative phosphorylation. The increased production of carbon dioxide stimulates respiration, So salicylates also stimulate the respiratory center directly in the medulla. The respiratory rate and depth increases, the PCO2 falls, and there will be respiratory alkalosis when this happens. Therapeutic doses of salicylate produce definite changes in the acid-base balance and electrolyte pattern. Compensating for the initial event, respiratory alkalosis is achieved by increased renal excretion of bicarbonate, accompanied by increased sodium and potassium excretion, therefore lowering the plasma bicarbonate so the blood pH returns to normal. Long-term use of salicylates alone is rarely associated with nephrotoxicity, but the prolonged and excessive ingestion of analgesics and analgesic mixtures containing salicylates in combination with other NSAIDs can produce papillary necrosis and interstitial nephritis. Low-dose aspirin, less than 100 milligrams daily, and lowers cardiovascular risk and is recommended for the prevention of MI or myocardial infarction and stroke in patients at elevated risk. At high therapeutic doses, more than 3 grams daily, salt and water retention can happen and lead to an increase in circulating plasma volume and decreased hematocrit. Cardiac output and work are increased, so those with carditis or compromised cardiac function may not have sufficient cardiac reserve to meet the increased demands, and congestive cardiac failure and pulmonary edema can occur. High doses of salicylates can produce non-cardiogenic pulmonary edema, particularly in older patients who ingest salicylates regularly over a prolonged period. Ingestion of salicylates may result in epigastric distress, heartburn, dyspepsia, nausea, and vomiting. Salicylates also may cause erosive gastritis and GI ulceration and hemorrhage. These effects occur primarily with acetylated salicylates because non-acetylated salicylates lack the ability to acetylate COX. Aspirin-induced gastric bleeding sometimes is painless and, if unrecognized, may lead to iron deficiency anemia. The daily ingestion of anti-inflammatory doses of aspirin, around 3 to 4 grams, results in average fecal blood loss of between 3 and 8 ml per day, as compared with about 0.6 ml per day in untreated subjects. Salicylates can cause hepatic injury, usually after high doses that result in plasma salicylate concentrations greater than 150 micrograms per ml. The injury is not an acute effect, but instead, its onset happens after several months of high-dose treatment. The majority of cases occur in patients with connective tissue disorders. There are usually no symptoms. Simply an increase in serum levels of hepatic transaminases can be seen, but some patients note right upper quadrant abdominal discomfort and tenderness. Overt jaundice is uncommon. The injury usually is reversible on discontinuation of the salicylates. The use of salicylates as an important factor in the severe hepatic injury and encephalopathy observed in Ray's syndrome. Large doses of salicylates may cause hyperglycemia and glycosuria and deplete liver and muscle glycogen. The effects of salicylates on uric acid excretion are markedly dependent on dose. Low doses of 1 or 2 grams per day may decrease urate excretion and elevate plasma urate concentrations. Intermediate doses of 2 or 3 grams per day usually do not alter urate excretion. Larger than recommended doses of more than 5 grams per day induce uricosuria and lower plasma urate levels. However, such large doses are tolerated poorly. Irreversible inhibition of platelet function underlies the cardioprotective effect of aspirin. If possible, aspirin therapy should be stopped at least 1 week before surgery. Patients with severe hepatic damage, hyperprothrombemia, vitamin K deficiency, or hemophilia should avoid aspirin because the inhibition of platelet hemostasis can result in hemorrhage. Salicylates ordinarily do not alter the leukocyte or platelet count, the hematocrit or the hemoglobin content. However, doses of 3 to 4 grams per day markedly decrease plasma iron concentration and shorten erythrocyte survival time. Aspirin can cause a mild degree of hemolysis in individuals with a deficiency of G6PD. Salicylate poisoning or serious intoxication most often occurs in children and sometimes is fatal. CNS effects, intense hyperpnea, and hyperpyrexia are prominent symptoms. The little dose of methyl salicylate, also known as oil of wintergreen, sweet birch oil, Gaultheria oil, betula oil, is considerably less than that of sodium salicylate. As little as 4 ml or 4.7 grams of this methyl salicylate may cause severe systemic toxicity in children. Mild chronic salicylate intoxication is called salicylism. This table shows us the para-aminophenol derivatives like the acetaminophen, its pharmacokinetic dosing and comparison to aspirin. Please familiarize yourself with this table. Acetaminophen or paracetamol or N-acetyl P-aminophenol is the active metabolite of phenacetin. It also has a fixed dose combination containing narcotic and non-narcotic analgesics. Acetaminophen is well tolerated, however, overdosage, about two-thirds of which are intentionally induced, can cause severe hepatic damage. The maximum FDA recommended dose of acetaminophen is 4 grams per day. Acetaminophen has analgesic and antipyretic effects similar to those of aspirin, but only weak anti-inflammatory effects. It is a non-selective COX inhibitor, which acts at the peroxide site of the enzyme and is thus distinct among NSAIDs. Oral acetaminophen has excellent bioavailability. The peak plasma concentration occurs within 30 to 60 minutes, and the half-life in plasma is about 2 hours. Acetaminophen is relatively uniformly distributed throughout most body fluids. Binding of the drug to plasma proteins is variable, but less than with other NSAIDs. Some 90 to 100% of drug may be recovered in the urine within the first day of therapeutic dosing, primarily after hepatic conjugation with glucuronic acid, sulfuric acid, or cysteine. Small amounts of hydroxylated and deacylated metabolites also have been detected. Please look at table 38-2. Children have less capacity for glucuronidation of the drug than do adults. A small proportion of acetaminophen is suitable for analgesic or antipyretic uses. This is given for patients in whom aspirin is contraindicated, such as in patients with aspirin hypersensitivity or children with a febrile illness and patients with bleeding disorders. The conventional oral dose of acetaminophen is 325 to 650 milligrams every 4 to 6 hours. The total daily dose, should not exceed 4 grams or 2 grams per day for chronic alcoholics. Single doses for children 2 to 11 years of age depend on age and weight. So it's around 10 to 15 milligrams per kilogram computed dose. No more than 5 doses should be administered in 24 hours. An injectable preparation is available. Acetaminophen usually is well tolerated. Therapeutic doses of acetaminophen have no clinically relevant effects on the cardiovascular and respiratory systems, platelets, or coagulation. The GI adverse effects are less common than with therapeutic doses of NSAIDs. Rash and other allergic reactions occur occasionally, but these are more serious and may be accompanied by drug fever and mucosal lesions. The most serious acute adverse effect of overdosage of acetaminophen is a potentially fatal hepatic necrosis. Hepatic injury with acetaminophen involves its conversion to the toxic metabolite NAPQI. In the setting of acetaminophen overdose, Hepatocellular levels of glutathione become depleted. Depletion renders the hepatocytes highly susceptible to oxidative stress and apoptosis. Renal tubular necrosis and hypoglycemic coma also may occur. Severe liver damage occurs in 90% of patients with plasma concentrations of acetaminophen greater than 300 micrograms per ml at 4 hours or 45 micrograms per ml at 15 hours after the ingestion of the drug. Activated charcoal, if given within 4 hours of ingestion, decreases toxicity, the acetaminophen absorption by 50 to 90% and should be administered if the ingested dose is suspected to exceed 7.5 grams. N-acetylcysteine or NAC is indicated for those at risk of hepatic injury. This functions by detoxifying the NAPQI. It both depletes the glutathione stores and may conjugate directly with the NAPQI by serving as a glutathione substitute. Aside from NAC, aggressive supportive care is warranted. This includes management of hepatic and renal failure if they occur, and intubation if the patient becomes obtunded. Hypoglycemia can result from liver failure, and plasma glucose should be monitored closely. Fulminant hepatic failure is an indication for liver transplantation. Diclofenac displays rapid absorption, extensive protein binding, and a half-life of 1 to 2 hours. The short half-life makes it necessary to give doses considerably higher than would be required to inhibit COX-2 fully. At peak plasma concentrations to afford sustained COX inhibition throughout the dosing interval. There is a substantial first-pass effect such that only 50% of this drug is available systemically. The drug accumulates in synovial fluid after oral administration, which may explain why its duration of therapeutic effect is considerably longer than its plasma half-life. Diclofenac is metabolized in the liver by a member of the CYP2C subfamily to 4-hydroxydiclofenac and other hydroxylated forms. After glucuronidation and sulfation, the metabolites are excreted in the urine 65% and bile 35%. Diclofenac is approved in the US for the long-term symptomatic treatment of rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, pain, primary dysmenorrhea, and acute migraine. Multiple oral formulations are available. The usual daily oral dosage is 50 to 150 milligrams given in several divided doses. Diclofenac also is available in combination with misoprostol, a prostaglandin. This combination retains the efficacy of diclofenac while reducing the frequency of GI ulcers and erosions. A 1% topical gel, a topical solution, and a transdermal patch are available for short-term treatment of pain due to minor strains, sprains, and bruises. A 3% gel formulation is indicated for topical treatment of actinic keratosis. In addition, an ophthalmic solution is available for treatment of postoperative inflammation following cataract extraction or temporary relief of pain and photophobia in patients undergoing corneal refractive surgery. Diclofenac produces side effects, particularly in the GI tract, in about 20% of patients. The incidence of serious GI adverse effects, hypertension, and myocardial infarction are similar to the COX-2 selective inhibitors. Hypersensitivity reactions can happen following topical application and systemic administration. Severe liver injury occurs in 6 to 11 per 100,000 regular users annually. Elevation of hepatic transaminases in plasma by more than three times the upper normal limit, indicating significant liver damage occurring in about 4% of patients. Indomethacin is a potent non-selective inhibitor of the COX. It also inhibits the motility of the PMN leukocytes, depresses the biosynthesis of mucopolysaccharides, and have a direct COX-independent vasoconstrictor effect. Oral indomethacin has excellent bioavailability. The peak concentrations occurs The peak concentrations occur 1 to 2 hours after dosing. The concentration of the drug in the CSF is low, but its concentration in synovial fluid is equal to that in plasma within 5 hours of administration. There is enterohepatic cycling of the indomethacin and its metabolites. The half-life in plasma is variable, perhaps because of the enterohepatic cycling, but averages about 2.5 hours. While indomethacin is estimated to be about 20 times more potent than aspirin, a high rate of intolerance limits its use. An intravenous formulation of the indomethacin is approved for closure of your PDA or patent ductus arteriosus in premature infants. The regimen involves the following: an intravenous administration of zero point 0.1 to 0.25 milligrams per kilograms every 12 hours for 3 doses, with the course repeated one time if necessary. Successful closure can be expected in more than 70% of neonates treated. The principal limitation of treating neonates is renal toxicity, and therapy is interrupted if the output of urine falls significantly. An injectable formulation of ibuprofen is an alternative for the treatment of patent ductus arteriosus. A very high percentage, around 35 to 50% of patients receiving indomethacin experience adverse drug reactions. GI adverse events are common and can be fatal. Elderly patients are at significantly greater risk. Diarrhea may occur and sometimes is associated with ulcerative lesions of the bowel. Acute pancreatitis has been reported, but rare, but is potentially fatal, and as well as cases of hepatitis. The most frequent CNS effect is severe frontal headache. Dizziness, vertigo, lightheadedness, and mental confusion may occur. Seizures have been reported as have severe depression, psychosis, hallucinations, and suicide. Hematopoietic reactions include neutropenia, thrombocytopenia, and rarely aplastic anemia. Indomethacin antagonizes the natriuretic and antihypertensive effects of furosemide and thiazide diuretics, and blunts the antihypertensive effect of beta receptor antagonists, AT1 receptor antagonists, and ACE inhibitors. For sulindac, tolmetin, and nabumeton, please refer to tables 38-1 and 38-2. Etodolac is an acetic acid derivative with some degree of COX-2 selectivity. A single oral dose, around 200 to 400 milligrams of etodolac, provides post-op analgesia that lasts for 6 to 8 hours. Etodolac also is effective in the treatment of osteoarthritis, rheumatoid arthritis, and mild to moderate pain, and the drug appears to be uricosuric. Sustained release preparations are available. Etodolac is relatively well tolerated. About 5% of patients who have taken the drug for a year or less discontinue treatment because of GI side effects, rashes, and CNS effects. Ketorolac is another acetic acid derivative and is a potent analgesic, but only a moderately effective anti-inflammatory drug. The use of ketorolac is limited to 5 days or less for acute pain and can be administered orally, intravenously, intramuscularly, or intranasally. Typical doses are 30 to 60 milligrams IM, 15 to 30 milligrams IV, 10 to 20 milligrams oral, and 31.5 milligrams intranasal. Pediatric patients aged between 2 and 16 years may receive a single IM, 1 milligram per kilogram up to 30 milligram, or IV, 0.5 milligram up to 15 milligrams dose of ketorolac for severe acute pain. Ketorolac has a rapid onset of action and a short duration of action. It is widely used in post-op patients, but it should not be used for routine obstetric analgesia. Topical ophthalmic ketorolac is approved for the treatment of seasonal allergic or seasonal allergic conjunctivitis and postoperative ocular inflammation. Ketorolac in a fixed dose combination with phenylephrine is indicated as an irrigation during cataract or intraocular lens replacement surgery to maintain pupil size, prevent miosis, and reduce post-op pain. The side effects of systemic ketorolac include somnolence, dizziness, headache, GI pain, dyspepsia, nausea, and pain at the site of injection. Serious adverse GI, renal, bleeding, and hypersensitive reactions to ketorolac may occur. Ibuprofen is absorbed rapidly and binds avidly to protein and undergoes hepatic metabolism. 90% is metabolized to hydroxylate or carboxylate derivatives. The half-life is about 2 hours, and there is slow equilibration with the synovial space, which means that its anti-arthritic effects may persist after plasma levels decline. In experimental animals, ibuprofen and its metabolites readily cross the placenta. Ibuprofen is supplied as tablets, chewable tabs, capsules, caplets, gel caps containing 50 to 600 milligrams, as oral drops, and as an oral suspension. An injectable formulation of ibuprofen is approved to close the patent ductus arteriosus in premature infants. Solid oral dosage forms containing 200 milligrams or less are available without a prescription. Ibuprofen is licensed for marketing alone and in fixed dose combinations with antihistamines, decongestants, famotidine, oxycodone, and hydrocodone. The usual dose for mild to moderate pain is 400 milligrams every 4 to 6 hours. 5 to 15% of patients experience GI side effects. Less frequent adverse effects include rashes, thrombocytopenia, headache, dizziness, blurred vision, and in a few cases, toxic amblyopia, fluid retention, and edema. Ibuprofen can be used occasionally by pregnant women. However, the concerns apply regarding third trimester effects, including delay of parturition. Excretion into breast milk is thought to be minimal, so ibuprofen also can be used with caution by women who are breastfeeding. Another propionic acid derivative is naproxen. Naproxen is absorbed fully after oral administration. Naproxen also is absorbed rectally, but more slowly than after oral administration. Naproxen is almost completely, or 99%, bound to plasma protein after normal therapeutic doses. The half-life of naproxen in plasma is variable around 9 to 25 hours. Age plays a role in the variability of the half-life because of the age-related decline in renal function and consequently longer half-life. Low doses should be prescribed in the elderly. Naproxen is extensively metabolized in the liver. About 30% of the drug undergoes 6-desmethylation, and most of this metabolite, as well as naproxen itself, is excreted as glucuronide or other conjugates. Metabolites of naproxen are excreted almost entirely in the urine. Naproxen crosses the placenta and appears in the milk of lactating women at about 1% of the maternal plasma concentration. Naproxen is indicated for juvenile and rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, pain, primary dysmenorrhea, tendonitis, bursitis, and acute gout. 1 to 10% of patients taking naproxen experience GI adverse effects that include heartburn, abdominal pain, constipation, diarrhea, nausea, dyspepsia, and stomatitis. Adverse effects with naproxen occur at approximately the same frequency as with indomethacin and other NSAIDs. CNS side effects include drowsiness, headache, dizziness, vertigo, and depression. Other common reactions include pruritus and diaphoresis. Rare instances of jaundice, impairment of renal function, angioedema, thrombocytopenia, and granulocytosis have been reported. The fifth type of NSAIDs is the phenamates or the antranilic acid. The phenamates include mefenamic acid, meclofenamate, and flufenamic acid. The pharmacological properties of the phenamates are those of the typical NSAIDs, and therapeutically they have no advantages over others in the class. Mefenamic acid and meclofenamate sodium are used in the short-term treatment of pain in soft tissue injuries, dysmenorrhea, and rheumatoid and osteoarthritis. These drugs are not recommended for use in children or pregnant women. Roughly 5% of patients develop irreversible elevation of hepatic transaminases, and diarrhea, which may be severe and associated with steatorrhea and inflammation of the bowel, also is relatively common. Autoimmune hemolytic anemia is a potentially serious but rare side effect. The fifth type is the enolic acids or the oxycams. The pharmacokinetics of piroxicam are described in Table 38-4. The usual daily dose is 20 milligrams. Piroxicam is absorbed completely after oral administration and undergoes enterohepatic recirculation. Estimates of the half-life in plasma have been variable. The average is 50 hours. Steady-state blood levels are reached in 7 to 12 days. Less than 5% of the drug is excreted in the urine unchanged. The major metabolic transformation in humans is hydroxylation of the pyridyl ring. And this inactive metabolite and its glucuronide conjugate account for about 60% of the drug excreted in the urine and feces. Approximately 20% of patients experience side effects with piroxicam, and about 5% of patients discontinue use because of these effects. Piroxicam may be associated with more GI and serious skin reactions than other non-selective NSAIDs. Meloxicam is another enolic acid approved for use in osteoarthritis, rheumatoid arthritis, and juvenile rheumatoid arthritis. The recommended adult dose of meloxicam is 7.5 to 15 milligrams once daily. Meloxicam demonstrates some COX-2 selectivity. There is significantly less gastric injury compared to piroxicam in subjects treated with 7.5 milligrams per day of meloxicam, but the advantage is lost with a dosage of 15 milligrams per day. Another type is the COX-2 selective NSAIDs. An example is your celecoxib. The bioavailability of oral celecoxib is not known. The peak plasma levels occur at 2 to 4 hours after administration, and this is bound extensively to plasma proteins. Most is excreted as carboxylic acid and glucuronide metabolites in the urine and feces. The elimination half-life is about 11 hours. The drug commonly is given once or twice daily during chronic treatment. Celecoxib is metabolized predominantly by your CYP2C9 and inhibits CYP2D6. Celecoxib is used for the management of acute pain for the treatment of osteoarthritis, rheumatoid arthritis, juvenile rheumatoid arthritis, ankylosing spondylitis, and primary dysmenorrhea. The recommended dose for treating osteoarthritis is 200 milligrams per day as a single dose or divided as 2 doses. In the treatment of rheumatoid arthritis, the recommended dose is 100 to 200 milligrams twice daily. Because of the cardiovascular hazard, physicians are advised to use the lowest possible dose for the shortest possible duration. Celecoxib confers a risk of myocardial infarction and stroke, and this appears to relate to dose and underlying risk of cardiovascular disease. Effects attributed to inhibition of prostaglandin production in the kidney, hypertension, and edema occur with non-selective COX inhibitors and also with celecoxib. The chronic use of celecoxib may decrease bone mineral density, particularly in older male patients. There is some suggestion that celecoxib may slow fracture healing and tendon to bone healing. Another type of COX-2 selective NSAID is your etoricoxib. Etoricoxib is a COX-2 selective inhibitor with selectivity second only to that of lumiracoxib. Please see figure 38-1. Etoricoxib is incompletely absorbed and has a long half-life of 20 to 26 hours. It is extensively metabolized before excretion. Patients with hepatic impairment are prone to drug accumulation. Renal insufficiency does not affect drug clearance. Etoricoxib is used for symptomatic relief in the treatment of osteoarthritis, rheumatoid arthritis, and acute gouty arthritis, as well as for the short-term treatment of musculoskeletal pain, post-op pain, and primary dysmenorrhea. The drug is associated with the increased risk of heart attack and stroke. Etoricoxib is not available in the US. NSAIDs have anti-inflammatory effects, but NSAIDs have minimal, if any, effect on progression of joint deformity. So these disease-modifying anti-rheumatic drugs or DMARDs can reduce the disease activity of rheumatoid arthritis and retard the progression of arthritic tissue destruction. Biological DMARDs are reserved for use in patients with persistent, moderate, or high disease activity and indicators of poor prognosis. The combination of NSAIDs with these agents is common. This is summarized in Table 38-5. DMARDs include a diverse group of small molecule non-biologically and biological agents. Please familiarize yourself with this table. Look at the different small molecules and the biologicals and the class or action. We'll now go to the pharmacotherapy of gout. Gout results from the precipitation of urate crystals in the tissues and the subsequent inflammatory response. Acute gout usually causes painful distal monoarthritis and can cause joint destruction, subcutaneous deposits or tophi, and renal calculi and damage. Gout affects 3% of the adult population of Western countries. The pathophysiology of gout is incompletely understood. Hyperuricemia, while a prerequisite, does not inevitably lead to gout. Uric acid, the end product of purine metabolism, is relatively insoluble compared to its hypoxanthine and xanthine precursors, and normal serum urate levels approach the limit of solubility. In patients with gout, hyperuricemia arises from underexcretion rather than overproduction of urate. Mutations of one of the renal urates or URAT1 are associated with hypouricemia. The urate tends to crystallize as monosodium urate in colder or more acidic conditions. Monosodium urate crystals activate monocytes macrophages through your toll-like receptor pathway, mounting an innate response. This results in the activation of your cryopyrin inflammasome, the secretion of your cytokines, including your interleukin-1 beta and TNF-alpha, endothelial activation, and attraction of neutrophils to the site of inflammation. Neutrophils secrete inflammatory mediators that lower the local pH and lead to further urate precipitation. The aims of the treatment are to decrease the symptoms of an acute attack, decrease the risk of recurrent attacks, and lower serum urate levels. The following substances are available for these purposes. These are drugs that relieve inflammation and pain like your NSAIDs, colchicine, glucocorticoids, or drugs that prevent inflammatory response to crystals like your colchicine and NSAIDs, or drugs that act by inhibition of urate formation like your allopurinol and febusoxstat, or to augment urate excretion like your probenecid. The NSAIDs have been discussed previously, and glucocorticoids are discussed in Chapter 46. This section focuses on drugs for treatment of gout like colchicine, allopurinol, febusoxstat, pegloticase, rasburicase, and the uricosuric agents probenecid and benzbromarone. Some other drugs used off-label to reduce uric acid levels or treat gout include losartan, fenofibrate, and canakinumab. We'll start with colchicine. Colchicine is considered a second-line therapy because it has a narrow therapeutic window and a higher rate of side effects, particularly at higher doses. It has antimitotic effects arresting cell division in G1 by interfering with microtubule and spindle formation. Depolymerization of microtubules by colchicine reduces neutrophil recruitment to inflamed tissues and neutrophil adhesion. Colchicine may alter neutrophil motility and decrease the secretion of chemotactic factors and superoxide ions by activated neutrophils. The colchicine limits monosodium urate crystal-induced NALP3 inflammasome activation and subsequent formation of interleukin 1 and interleukin 1B and interleukin 18. Absorption of oral colchicine is rapid but variable. Peak plasma concentrations occur 0.5 to 2 hours after dosing. Food does not affect the rate or extent of colchicine absorption. In plasma, 39% of colchicine is protein-bound primarily to albumin. The formation of colchicine tubulin complex in many tissues contributes to its large volume of distribution. There is significant enterohepatic circulation. The exact metabolism of colchicine in humans is unknown. In healthy volunteers, 40 to 65% of the total absorbed oral dose of colchicine is recovered unchanged in the urine. The kidney, liver, and spleen also contain high concentrations of colchicine, but it apparently is largely excluded from heart, skeletal muscle, and brain. The plasma half-life of colchicine is about 31 hours. The drug is contraindicated in patients with hepatic or renal impairment requiring concomitant therapy with CYP3A4 or P-glycoprotein inhibitors. Colchicine is not removed by hemodialysis. A minimum of 3 days, but preferably 7 to 14 days, should elapse between courses of gout treatment with colchicine to avoid cumulative toxicity. Patients with hepatic or renal disease and dialysis patients should receive reduced doses or less frequent therapy. For elderly patients, adjust the dose for renal function. This is effective in roughly 2/3 of patients if given within 24 hours of attack onset. The pain, swelling, and redness will abate within 12 hours and are completely gone within 48 to 72 hours. The regimen approved for adults recommends a total of 2 doses taken an hour apart. So first, 1.2 milligram, that is 2 tablets at the first sign of a gout flare, followed by half of the dose, 0.6 milligrams or 1 tablet 1 hour later. The typical dose for prophylaxis in patients with normal renal and hepatic function is 0.6 milligram taken orally 3 or 4 days per week for patients who have less than 1 attack per year, or 0.6 milligrams daily for patients who have more than 1 attack per year, and 0.6 milligram up to 2 times daily for patients who have severe attacks. Nausea, vomiting, diarrhea, and abdominal pain are the most common untoward effects and the earliest signs of impending colchicine toxicity. Acute intoxication causes hemorrhagic gastropathy. Other serious side effects of colchicine therapy include myelosuppression, leukopenia, granulocytopenia, thrombocytopenia, aplastic anemia, and rhabdomyolysis. Life-threatening toxicities are associated with administration of your concomitant therapy with the P-glycoprotein or CYP3A4 inhibitors. Both allopurinol and its primary metabolite oxypurinol or alloxanthine reduce the urate production by inhibiting the xanthine oxidase, which converts xanthine to uric acid. In the absence of allopurinol, the dominant urinary purine is uric acid. Allopurinol is absorbed relatively rapidly after oral ingestion, and peak plasma concentrations are reached within 60 to 90 minutes. 20% is excreted in the feces in 48 to 72 hours, presumably as unabsorbed drug, and 10 to 30% is excreted unchanged in the urine. The remainder undergoes metabolism mostly to oxypurinol. The plasma half-life of allopurinol and oxypurinol is about 1 to 2 hours and 18 to 30 hours, respectively. Allopurinol is available for oral and IV use. Oral therapy provides effective therapy for primary and secondary gout, hyperuricemia, secondary to malignancies, and calcium oxalate calculi. The goal of the therapy is to reduce the plasma uric acid concentration to less than 6 milligrams per DL and typically less than 5 milligrams per DL in patients with tophi to accelerate the clearance of monosodium urate. In the management of gout, it is customary to antecede allopurinol therapy with the colchicine and to avoid starting allopurinol during an acute attack. Fluid intake should be sufficient to maintain daily urinary volume greater than 2 liters. Slightly alkaline urine is preferred. The usual daily dose in children with secondary hyperuricemia associated with malignancies is 150 to 300 milligrams, depending on age. Allopurinol is also useful in lowering the high plasma concentrations of uric acid in patients with Lesch-Nyhan syndrome or orphan designation, and thereby prevents the complications resulting from hyperuricemia. Allopurinol generally is well tolerated. The most common adverse effects are hypersensitivity reactions that may manifest after months or years of therapy. Rarely, there will be toxic epidermal necrolysis or Stevens-Johnson syndrome. This is contraindicated in patients with hypersensitivity or nursing mothers and children, except in Lesch-Nyhan syndrome. Febuxostat is rapidly absorbed with maximum plasma concentrations. Febuxostat is a non-purine inhibitor of xanthine oxidase. The absolute bioavailability is unknown, and magnesium hydroxide and aluminum hydroxide delay absorption by 1 hour. Food reduces absorption slightly. Febuxostat's half-life is 5 to 8 hours. This is extensively metabolized by both conjugation through UGT enzymes and oxidation by CYPs and non-CYP enzymes, and has elimination by both hepatic and renal pathways. Mild to moderate renal or hepatic impairment does not affect its elimination kinetics relevantly. Febuxostat is approved for hyperuric patients with gout attacks, but is not recommended for treatment of asymptomatic hyperuricemia. It is available in 40 and 80 milligram oral tablets. A dose of 40 milligrams per day lowers the serum uric acid to similar levels as 300 milligrams per day of allopurinol. Therapy should be initiated with 40 milligrams per day, and the dose increased if the target serum uric acid concentration is not reached within 2 weeks. The most common adverse reaction in clinical studies were liver function abnormalities, nausea, joint pain, and rash. Liver function should be monitored periodically. There was a higher rate of MI or myocardial infarction and stroke in patients on this drug than on allopurinol. Uricase or pegloticase catalyzes the enzymatic oxidation of uric acid into allanton. And this is administered by infusion. Pegloticase is used for the treatment of severe treatment refractory chronic gout or when use of other urate-lowering therapies is contraindicated. The drug's efficacy may be hampered by the production of antibodies against the drug. Anaphylactic reactions and hemolysis in G6PD deficient patients have been associated with the use of pegloticase. Other frequently observed adverse reactions include vomiting, nausea, chest pain, constipation, diarrhea, and erythema, pruritus, and urticaria. Another drug is rasburicase. This is a recombinant uricase that has been shown to lower urate levels more effectively than allopurinol. It is indicated for the initial management of elevated plasma uric acid levels in pediatric and adult patients with leukemia, lymphoma, and solid tumor malignancies who are receiving anti-cancer therapy expected to result in tumor lysis and significant hyperuricemia. The experience with rasburicase for treatment of gout is limited because of the formation of activity-limiting antibodies against the drug. Hemolysis in G6PD deficient patients, hemoglobinemia, acute renal failure, and anaphylaxis have been associated with the use of rasburicase. Other frequently observed adverse reactions include vomiting, fever, nausea, headache, abdominal pain, constipation, diarrhea, and mucositis. The actions of another therapy of gout is uricosuric agent called probenecid. The actions of probenecid are confined largely to inhibition of the transport of organic acids across epithelial barriers. Probenecid also inhibits the reabsorption of uric acid by oats, principally the urat-1. The uricosuric action of probenecid is blunted by the co-administration of salicylates. Probenecid also inhibits the tubular secretion of a number of drugs such as methotrexate and the active metabolite of clofibrate, among others. Probenecid is absorbed completely after oral administration, and the peak plasma concentration are reached in 2 to 4 hours. The half-life of the drug in plasma is dose-dependent and varies from less than 5 to more than 8 hours. Between 85 to 90% of the drug is bound to plasma albumin. The 5 to 15% of unbound drug is cleared by glomerular filtration and active secretion by the proximal tubule. A small amount of probenecid glucuronide appears in the urine. It is also hydroxylated to metabolites that retain their carboxyl function and have uricosuric activity. Probenecid is marketed for oral administration alone and in combination with colchicine. The starting dose is 250 mg twice daily, which can be increased over 1 to 2 weeks to 500 to 1,000 mg twice daily. Probenecid increases urinary urate levels. Liberal fluid intake, therefore, should be maintained throughout therapy to minimize the risk of renal stones. Probenecid should not be used in gouty patients with nephrolithiasis or with overproduction of uric acid. Higher doses of probenecid, around 1 to 2 grams per day, are used as an adjuvant to prolong the dwell time of penicillin and other beta-lactam antibiotics in the body. Probenecid is well tolerated. Approximately 2% of patients develop mild GI irritation. The risk is increased at higher doses. It is ineffective in patients with renal insufficiency and should be avoided in those with creatinine clearance of less than 50 ml per minute. Hypersensitivity reactions usually are mild and occur in 2 to 4% of patients. Substantial overdosage with probenecid results in CNS stimulation, convulsions, and death from respiratory failure. The last drug the second to the last drug is benzbromarone. It is a reversible inhibitor of the urate and ion exchanger in the proximal tubule. Hepatotoxicity reported in conjunction with its use has limited its availability. The drug is absorbed readily after oral ingestion, and the peak plasma levels are achieved in about 4 hours. It is metabolized to monobrominated and dehalogenated derivatives, both of which have uricosuric activity and is excreted primarily in the bile. As the micronized powder, it is effective in a single daily dose ranging from 25 to 100 milligrams. It is effective in patients with renal insufficiency and may be prescribed to patients who are either allergic or refractory to other drugs used for the treatment of gout. Preparations that combine allopurinol and benzbromarone are more effective than either drug alone in lowering serum uric acid levels, in spite of the fact that benzbromarone lowers plasma levels of oxypurinol, the active metabolite of allopurinol. The uricosuric action is blunted by aspirin or sulfenpyrazone. The last drug for the pharmacotherapy of gout is lesinurad. This inhibits the URAT1 and OAT4 transporters, thereby reducing renal uric acid reabsorption. Lesinurad is rapidly absorbed after oral administration and has a bioavailability of about 100%. Lenisorad is largely bound to plasma albumin and other plasma proteins, around 98%. The elimination half-life is about 5 hours, and the clearance is 6 liters per hour. CYP2C9 is the major metabolizing enzyme. Lesinurad and its metabolites are excreted in the urine and feces. This is marketed for the treatment of gout in patients who have not achieved the target serum uric acid levels with an xanthine oxidase inhibitor alone. It should not be used for the treatment of asymptomatic hyperuricemia or as monotherapy. Lesinurad has been labeled with a black box warning because of a risk of acute renal failure. That is more common when it is used without a xanthine oxidase inhibitor. The risk of nephrolithiasis is increased when lesinurad is given alone. Other adverse reactions reported during clinical trials include headache, influenza-like symptoms, and gastroesophageal reflux. That ends my lecture. Here's one of my favorite fairy tale with a quote that says, "I want to tell you a secret that will see you through all the trials that life can offer. Have courage and be kind." Thank you for watching. Stay safe.